Hello, good afternoon, everyone, and thank you for attending our discussion today addressing the burden of hospital-onset bacteremia with a focus on risk factor mitigation strategies. Today, I'm joined by a few of my medical affairs colleagues from Becton Dickinson and Company, who are subject matter experts in vascular access, surgical care, urology care, as well as infectious diseases and infection control. During this presentation, we'll review key clinical and economic burden data around hospital-onset bacteremia, as well as key sources that we've studied, including vascular access devices, such as what we see with CLABSI, urine, such as what we see with catheter-associated UTIs or CAUTIs, and other hospital-onset UTIs as well, and HOB associated with surgical site infections. So to start, I'd like to provide a little bit of context around hospital-acquired infections in general. Most importantly, they are in the top 10 leading causes of death in the United States, resulting in nearly 100,000 deaths each year. When it comes to cost, they're attributable to excess healthcare costs of nearly $30 billion, and a staggering 1 in 31 patients contract at least one hospital-acquired infection daily. So this just highlights that despite our best efforts to date, hospital-acquired infections or HAIs remain a significant issue. So let's focus our attention on one HAI that has been gaining the attention of health systems and regulatory agencies across the United States. Hospital-onset bacteremia, or HOB, that we're going to talk about moving forward. And by definition, this is essentially any bloodstream infection where bacterial or fungal pathogen is identified starting on day 4 or later during a hospital admission. This HAI is a bloodstream infection from any source, regardless of procedure or device. So it is different from what we're kind of accustomed to, where HAIs like CLABSI and CAUTIs have to be attributable to a certain medical device. HOB can really come from any device or any source, and so it really covers a wider range of infections than traditional targets that have been mandatory reportable HAIs. This is why this patient safety metric was initially proposed by the CDC and later endorsed by the National Quality Forum as well as Battelle. And so here I want to briefly review what has been proposed by NHSN during their last year's annual training when this metric will be reportable. As I mentioned before, HOB event is really a bacteremia that is acquired on hospital day 4 or later, or I should say identified on hospital day 4 or later during an admission. And that would be the primary metric that's reported. But they also plan to collect complementary metrics such as blood culture utilization for both testing prevalence as well as intensity to ensure that we continue with diagnostic stewardship efforts, as well as blood culture contamination rates to see that we're truly meeting the CLSI guidance of less than 1% blood culture contamination rates. So important, of course, to identify true infections when they occur. Other complementary metrics would include community onset bacteremia and fungemia, as well as matching commensal HOB events, and those that are typically not, those patients that might be excluded from HOB metrics, specifically those patients who are thought to not have preventable risk factors. That might include immunocompromised patients or others, but on that point, we're not really clear to date as that has not yet been announced. And so one other thing I wanted to share that I thought was really interesting was in response to the CDC proposing this new safety metric and after its endorsements, the American Hospital Association launched a survey of hospital leaders across the United States to really understand what their perceptions are on the top contributors to HOB, those sources, as well as preventability of HOB. And so if I draw your attention to the right of the slide, to that table, This is really where the rankings fell according to hospital leaders. So if you look at the top line, central line catheters or CLABSIs, that was ranked as #1 contributor as well as the #1 preventable source of HOB. Right under that is urinary source infections, ranked #2 as a contributor to HOB, but only moderate preventability. So why I think this might be interesting, again, this is subjective data, but if you think about these top two sources, and then the third being pneumonia, which we know VAP is another reportable HAI, it's unclear as to whether these results might be biased because these are already mandatory reportables and so probably top of mind for healthcare organizations, or if those are truly the #1, 2, and 3 sources for HOB. But it is interesting on the other side, if you look at preventability, whether they're the highest source or not, there's really moderate preventability for some or low preventability for others. And so that just kind of speaks to, you know, our infection prevention efforts moving forward. The last thing I'll point out, peripheral IVs were the last on this list, but they were ranked as second most preventable for HOB. So again, this is subjective data, but what we want to do right now is dive into more objective data. And so who I'd like to introduce at this time is Dr. Calvin Yu, who has been leading the charge in generating evidence to really dive deeper into the sources of HOB. So Dr. Yu, I'll turn it over to you.
Thanks, Sam. So my name is Calvin Yu. I'm an infectious disease internal medicine physician and currently the Vice President of Medical Affairs at Becton Dickinson. And the 17 years before that, I worked at Kaiser Permanente, where I was their former Chief of Infectious Diseases and Chief Integration Officer. And so obviously have an interest in this topic. So the first of three papers I'll go over is a clinical outcomes assessment of both HOB and CLABSI, which is just a subset of HOB, as you know. This was a large study of 41 hospitals yielding 400 plus CLABSI events and 1,500 plus non-CLABSI HOB. And we compared those patients to 1 to 5 matched controls, accounting for the variables of age, ICU status, primary DRG, ICD, and primary procedure codes. And on top of that, the control group could not have any type of infection as defined as any positive culture within that admission hospital stay. And so the clinical insights when we compared the two groups were as follows. First of all, at a high level, HOB occurred at least 4 times more than CLABSI. HOB events incurred approximately 12 to 17 days extra length of stay, added $25,000 to $55,000 extra cost of care per HOB event. And CLABSI and non-CLABSI HOB both had greater than 3 times higher mortality versus those controls, and both had higher readmission risk within 30 days, which can further impact your reimbursement for that readmission. So it's pretty clear that CLABSI and non-CLABSI HOB cases are associated with significant and similar increases in morbidity, mortality, and cost. And to our knowledge, this is the first paper to assess all three. And it's worth to note that HOB is not currently mandated. And so this is already happening in your facilities with high mortality, high morbidity, and cost of care. The last thing I'll add is that based on all of the blood cultures that we reviewed in this cohort, about 3 to 8% of the blood cultures were likely contaminated blood cultures. And to Sam's point, with the new CLSI guidelines of less than 1%, there's probably an opportunity for resource optimization and workflow efficiencies from that angle. So to talk more about intravascular devices and HOB, I'm going to hand it over to our Med Affairs Marty for his insights.
Great. Thanks, Dr. Yu. Hi, everyone. My name is Marty Villegas. I am the Director of Medical Affairs for the U.S. MDS business here at BD. So I'm going to take a couple of minutes and talk about some of the risk factors and, specifically the modifiable risk factors. So when we think about CRBSI risk factors, let's focus on what are considered to be those modifiable risk factors as it relates to placing or caring for a vascular access device. So as you can see on the slide, there are many. So from selecting the proper device to maintaining asepsis, or sterility when placing and caring for these devices. They all are part of the what is considered modifiable risk factors. So then moving through the wheel, and these are in no particular order, proper skin disinfection prior to placement, utilizing visualization technology to assist with improving placement success, then the type of dressing, flushing practice, which all fall under care and maintenance bucket, in addition to all the other pieces that fall into the care and maintenance bucket, such as stabilization, proper disinfection prior to accessing the device or dressing changes. And these here all play a role and impact dwell time as well. So as you can see, all these risk factors are surrounded by the training and education wheel. So whether it's training on safe and effective use of a product or care and maintenance of a device that aligns to guidelines and standards, education is a constant perpetual need. In September of 2024, the National Quality Forum, or NQF, published the Hospital-Onset Bacteremia and Fungemia Playbook. The guide is a resource for hospitals to implement or improve their hospital-onset bacteremia and fungemia prevention, identification, and treatment programs. The guide identifies 4 phases and action plans. Phase 1 is to create that shared vision and buy-in within your facility or system. Phase 2 is to define your current state and assess where you can identify areas for improvement. Phase 3 rolls into, okay, we identified these areas for improvement. Now we need to implement changes in those areas that were identified in that phase. And then lastly, phase 4 is to promote sustainability of the program. The beauty of the NQF playbook is it provides a starting point if needed, as well as helping facilities expand on what they're already doing to improve upon current initiatives and strategies to help mitigate the risk of hospital-onset bacteremia and fungemia, or HOB. So here, when we talk about vascular visualization, the Infusion Nurses Society states that vascular visualization technology should be used to increase insertion success of the most appropriate, least invasive vascular access device, reduce insertion-related complications, and to use ultrasound to assess the size and caliber, or diameter and length, of the intravenous path, as well as other anatomical structures prior to the insertion to identify vascular anomalies such as an occlusion or thrombus, or other structures such as valves, arteries, and nerves. Technology is available to help clinicians be more successful in placing vascular access devices properly with increased success, minimizing the need to escalate for unnecessary, more invasive device, and to reduce insertion-related complication. Ultrasound guidance can improve that first-time success and identify veins, arteries, and associated structures, like we talked about before, nerves, to reduce the risk of nerve injury that obviously cannot be seen by the naked eye. When it comes to flushing, the Infusion Nurses Society, the Infusion Therapy Standards of Practice, states that vascular access devices should be assessed for patency, flushed and aspirated for blood return prior to each infusion to assess catheter function and prevent complications, as well as being flushed after every medication administration. The standard also states to use commercially manufactured pre-filled flush syringes when available to reduce the risk of CABSI and to disinfect the connection surface and the sides of the needleless connector attached to any vascular access device to reduce the introduction of intraluminal microbes. Additionally, the World Health Organization states that we should be flushing vascular access devices after administration. So flushing a device is such a routine procedure that is often taken for granted. When you think about how many times a clinician accesses a device to assess patency or to flush the device, there are many opportunities here for contamination if not done properly. Training, education, and products designed to drive compliance with standards related to the disinfection of the device prior to access can help mitigate the risk of contamination. Now, when we talk about care and maintenance, it's a continuum, right? It doesn't live in a silo. Care and maintenance crosses many, many, many sections of vascular access. So from insertion to removal, the vascular access device could see more than 200 touches. So when you think about it, the insertion of the vascular access device is just a small snapshot in the life of the device. Good care and maintenance is imperative to the life of the vascular access device. One of them is the use of add-on devices. So INS standards recommend limiting add-on devices whenever possible to decrease the risk of excessive manipulations, disconnections, and contamination. but we all know there are many facets of good care and maintenance that may prolong the life of a vascular access device. Products that have been proven to reduce the risk of infection, provide stabilization, promote proper flushing technique, and insertion kits designed to guide the clinician to follow what the current practice standards and guidelines are saying are just a few. Of course, training and education to current practice guidelines and product instruction for use play a vital role here as well. So now let's talk about catheter dwell times. So again, the infusion nurses therapy standards of practice states that vascular access devices are removed only when clinically indicated and not at a predetermined time frame. Variations in practice, products, and policy have been shown to lead to complications. Examples of these complications include infection, occlusion, dislodgement, phlebitis, and infiltration and extravasation. So this makes us ask ourselves, what risk mitigation strategies can we implement to help reduce this catheter failure and extend our dwell times? Whether they occur at placement or during care and maintenance, whether peripheral or central lines, remember that most vascular access complications can be prevented. So let's review some of these risks and how we may be able to mitigate them. So when we're talking about CRBSI, selecting the proper site, avoiding areas of flexion, disinfecting the skin properly, and practicing proper aseptic technique during insertion, access, and maintenance all can help mitigate the risk here. Moving over to occlusions, using the recommended flushing and locking procedures and preventing catheter dislodgement through appropriate catheter securement may also help mitigate the risk of occlusions. With dislodgement, avoiding areas of flexion whenever possible when we are selecting that insertion site, and using a securement device can help with the dislodgement risk. And then phlebitis, selecting the appropriate device for the intended therapy, managing the vein to catheter ratio to allow for adequate hemodilution, stabilizing the catheter, and practicing proper aseptic technique during insertion, access, and maintenance all play a vital role in mitigating the risk for phlebitis. And lastly, infiltration and extravasation. We want to assure that we select the appropriate vein for the insertion and use ultrasound guidance to visualize veins when possible. Also, selecting the appropriate device based on the intended therapy, type, length, gauge, and again, stabilizing that catheter and device adequately, and routine site assessment can all aid in early recognition of an infiltration or extravasation. So in isolated and in aggregate, all of these risk factors could lead to a bloodstream infection. And with that, I'm going to turn it back over to Dr. Yu.
Okay, thanks, Marty, for that great information. So the second paper, we attempted to shed light on urine as a source of HOB. And so as you saw in Sam's summary of the American Hospital Association survey, urine is thought to be a large source. If any of you have rounded in the inpatient side for a couple decades or more, that will probably be your suspicion too. Famously, England and the National Health System, they are tracking HOB specific types, E. coli, Klebsiella, and Proteus, because they've had problems with quality of care and high morbidity and mortality in patients that had urine infections from those three pathogens. And so they're tracking both HOB and community onset bloodstream infections with those pathogens. So you know, the world basically, and similar in Italy and Japan, Japan, and Germany have their own HOB metrics. And so this is not a new phenomenon, but it is new at looking at urine as a source with contemporary data like we've done in this paper. And so basically, we also compared this cohort with controls like the other paper, and the results showed that CAUTI and non-Foley catheter hospital-onset UTI, which we affectionately called non-CAUTI HOTI, they both added incremental cost of care per event, about $9,000 per CAUTI event and about $6,000 additional for a non-CAUTI HOTI. And both added approximately 3 days length of stay, and CAUTI had a statistically higher mortality risk compared to controls. So at a very high level, when you unpack this data, I think the best soundbite is approximately 8% of CAUTIs evolve into an HOB event. And for every one CAUTI that turns into an HOB, there are 3 other non-catheter associated UTI on the hospital onset period that do the same. And so therefore UTIs and urine are a huge source of traceable HOB events. Moreover, approximately 30% of positive urine cultures were likely false positive in this analysis. And there's no standard like the CLSI blood culture false positive guidelines. Um, and so, it's up to you to see if that actually is above or below what you are at your healthcare system. But it does bring up the good point of the importance of minimizing false positive, in this case, urine cultures, but also from the last paper, false positive blood cultures, so that the clinicians can really focus on getting that definitive antimicrobial therapy on the true infections for patient safety reasons. And also there's the issue of, when you use antibiotics for a false positive culture, you're contributing to risk factors for antimicrobial resistance and C. difficile colitis, which is also a currently reportable HAI. So a lot of potential areas for improvement in this space of urine. And so for more on the risk factors that together could contribute to a hospital onset UTI, I'm going to turn it over to my colleague, Danielle.
Thanks so much, Calvin. And a warm welcome to our audience today. Despite everything we know, hospital onset UTIs remain common. Why? 3 buckets stand out as key drivers. First, prolonged indwell time. The longer the catheter remains in place, the higher the infection risk. Second, contamination. Every touch point from insertion through maintenance is an opportunity for bacteria to enter the urinary tract. And finally, practice variation. You've seen it. Different hospital, different shift, or a different nurse, different approach, and sometimes different outcomes. These aren't just clinical issues, they're system-level challenges. Today, we'll explore how targeted tools and products can help us drive consistent best practice. Next slide, please, Sam. HOB continues to challenge acute care settings, often tied to device use, as discussed, and procedural variation. The product groups on this slide are designed to be part of a bundled care solution that can help mitigate potential infection risks. First, external urinary devices, or externals, used for non-invasive urine management, might help us reduce our reliance on indwelling urinary catheters. These include a wide range of offerings, from traditional sheath-style condom catheters to newer suction-assisted externals, and in more recent years, now include more equitable external options for females too. Perhaps the most robust evidence to date is the 2024 prior Medding Systemic Review and Meta-Analysis in Infection Control and Epidemiology. Overall, externals alone showed a trend of reduced indwelling COTI rates, though not statistically significant. However, COTI reductions were statistically significant among studies describing the use of protocols. Patient selection is very important with externals and is supported by the IPCARE algorithm, an evidence and consensus-based algorithm published in JWOCN in 2020 by Gray et al. The IPCARE algorithm supports the use of selection of patients that meet criteria, patients that require strict output measurements or strict I's and O's, patients that are incontinent, patients that are not candidates for toileting program, but they should not be used for convenience. The consensus algorithm supports the use of externals overnight to maximize patient sleep benefits. And it also gives guidance on patient transfers and patient mobilization, which is so important in our acutely ill patient population. Second, coated indwelling catheters. These delay or reduce biofilm formation and minimize bacterial adherence. Evidence is currently underdeveloped with mixed results as patient populations and technologies vary in the relatively few studies that we have available. There is no current consensus or clinical guidelines for routine use. I like to think of this one as a tool in the toolbox, the right product for the right patient at the right time. They may be appropriate in select patient populations or long-term catheterization scenarios per hospital protocols or as ordered by the provider. Third, fecal containment systems, perhaps the most underestimated. Their importance lies in reducing potential contact and contamination with one of the most common pathogens seen in UTIs, E. coli. They are increasingly supported in the literature as part of bundled care approaches, such as the American Nurses Association CLADI prevention tools, Wilkerson et al. That was an AJIC in 2020. Fourth, we have Peri cleaning wipes. No universal standard yet on exactly what to use. Some are Castile soap towelettes. Some, some folks use sterile water, saline. The key takeaway message is just do it, as bundled care models continue to emphasize the importance of consistent hygiene through peri-care and Foley care. Next, indwelling catheter trays. These may reduce procedural variations by standardization of catheter insertions and often offer evidence-based designs to support training and compliance. And finally, closed system trays, intended to prevent pathogen ingress and protect against external contaminants as recommended by the CDC guidelines and are commonly part of bundled care models. Together, these products support a strategy as a part of bundled care models to address factors that could lead to hospital onset UTIs by addressing both procedural integrity and device-related risks. Thanks so much for your time today. Back to you, Dr. Yu.
Thanks, Danielle. So we're going to shift gears a little bit. We also conducted an analysis for surgical site infections and associated HOB co-occurrence in the same hospital admission. For this analysis, we used two definitions of surgical site infections. One, I think the viewership will be well familiar with. It is literally the infection prevention department uploading data to the NHSN, vetting and verifying, yes, this is a SSI. The other method was from a couple of papers that were published by other researchers where they used ICD codes to identify surgical site infections. So for the first, with the IPC uploaded to NHSN, we had 38 hospital worth of data. And then for the ICD coded definition, it was those 38 hospitals plus another approximately 50 for a total of 80. And so the results were as follows. So for the surgical site infection admissions alone, and so this is with the cohort of 38 directly reported NHSN SSIs, we showed compared to controls that an SSI was associated with 11 days extra length of stay, an incremental cost increase of about $30,000 median addition. And furthermore, SSI admissions had a 6 times higher risk for developing an HOB compared to patients that underwent a similar or same procedure with no SSI. And that's where the other cohort with the other definition of ICD coded SSIs came in. We wanted to see if that was directionally aligned with a different definition. And indeed, with that ICD coded defined SSIs with 80 hospitals, again, it was a 6 times higher risk for HOB. So that statistic seems pretty solid no matter which definition of SSI you're using when examining real world evidence. In addition, approximately 3 to 12% of surgical site admissions experienced HOB events depending on the type of surgery. And so when we analyze surgical site admissions in the second part of the paper with an HOB event, we compared them to patients that had the same or similar procedures and had an SSI, but without the HOB component. So we really tried to isolate the HOB component. And so again, we found that in this cohort compared to controls, there's additional $24,000 spent in cost of care. and an added 6 days length of stay in surgical site infection patients with an HOB event during that same SSI admission. So the clinical burden of patients with an SSI is significant, and there's compounding deleterious outcomes with SSI with an HOB, obviously. And the risk appears to be 6 times higher, no matter which definition you look at. And so it's pretty critical, given that SSIs are currently mandated reportable and it's linked further downstream with HOB, or for finding ways to help to mitigate risk factors for that initial SSI. And that might not only help with your SSI site infection care program, but that might also affect the further downstream associated HOB risk. So for more on the former, on ways to mitigate SSI risk, I'm going to hand it over to our surgical segment medical affairs colleague, Lena. Lena, over to you.
Thank you, Dr. Yu. So my name is Lena Pearson. I'm the Associate Director here for Medical Affairs at the surgery platform. And as everyone's aware, I mean, in the OR, the clinical challenge is great. Surgical outcomes and risk of SSI and HOB are influenced by many factors. And these factors include patient factors such as obesity and diabetes, preoperative and surgeon factors with the use of drains or even staples, organizational factors and care delivery problems. Perioperative and intraoperative factors are where I'm going to focus on the next 2 slides. But the surgical continuum is equally important from the time the patient enters that hospital to the time of exit and discharge. All of these factors must be considered together. You can see there are many variables on the slide here, and which can result in the surgical outcome of a patient. What's important for us to remember is that any one of these factors can lead to failure of an SSI. HAIs are multifactorial, and many times not just one broken link in that chain. And because of this, there are many different strategies in which we could require to reduce an SSI risk to the lowest possible extent. The most successful method of implementation to prevent SSIs are the use of a bundled strategy to address multiple risk factors simultaneously. Next slide. So I will explore 4 critical areas that we can significantly impact surgical outcomes. And these 4 are skin antisepsis and hair removal, intraoperative irrigation, hemostats and sealants, and then hemodynamic monitoring. Each of these will play a vital role in reducing surgical site infections, improving efficiency, and enhancing patient safety. So let's just focus on the first one. Hair removal is often necessary for clear visualization of the surgical site, but how we remove that hair truly does matter. Clippers are preferred over razors to avoid nicks, cuts, and abrasions on the skin, and timing is key. Removal should happen just before surgery. A vacuum-assisted device can reduce airborne contamination and loose hair and airborne particles that can contaminate that surgical field. Studies have shown that vacuum-assisted clipping significantly reduces microbial load and airborne dispersal of hair. It should be standard on all procedures if clipping is necessary. As we progress to skin antisepsis is our first line of defense. It lays a good foundation on that skin prior to procedure, and it is valuable for good patient outcomes. An ideal skin antiseptic should be a 2% chlorhexidine and a 70% isopropyl alcohol because it offers a broad spectrum microbial reduction. It's got low systemic absorption, has minimal toxicity, and an important to note is the residual activity is beyond our surgical procedure, which is key. Along with an ideal antiseptic, standardization application technique, as well as full dry time, are essential for safety and efficacy. As we move on to intraoperative factors for mitigation, wound irrigation and hemostatic utilization are key components of that strategy as well. Wound irrigation is more than just rinsing. It's a mechanical cleansing process that removes bacteria and debris. Irrigation solutions should be non-toxic. They should be applied appropriately with amount of pressure in that wound bed. They should also follow that CDC and SHA guidelines with the recommendation of a PPI irrigation. An ideal surgical irrigation solution should achieve 99.99% of bacterial reduction, as well as a 4-log biofilm reduction in just 1 minute. Thoughts should be really focusing on the sterility of the irrigation with a ready-to-use or a pre-mixed solution versus mixing on the back table. Reduce that variability and consistency in practice. The USP 797 standard should also be taken into serious consideration. A pre-mixed or ready-to-use solution can reduce variability and contamination risk. It also can streamline the workflow to potentially reduce OR setup time. So as we look at the third critical area of hemostatic agents and sealants, they're really crucial for controlling bleeding and improving visualization. Hemostats and sealants are indicated in the surgical procedures as an adjunctive device to assist and control when pressure or ligature or just really are ineffective or impractical. These agents should be absorbable, biocompatible materials that resorb within that body within 24 to 48 hours, but not all hemostatic agents are equal in performance. And I think it's imperative that we're making sure that they're not nitises for infection as well. These agents can reduce operative time and support better outcomes. Lastly, early detection of hemodynamic instability can prevent serious complications, and real-time monitoring helps guide fluid and pharmacological interventions. Staff must be trained to interpret and act on these trends quickly, to integrate monitoring those decision-making processes for safer and more responsive care. Hemodynamic optimization really should be through a goal-directed therapy, and it should demonstrate and does demonstrate the reduction of complications like acute kidney injury as an SSI. So a unified approach is key by focusing on 4 of these 4 pillars: skin prep and clipping, wound irrigation, hemostats, and hemodynamics. We can create a safer, more efficient surgical environment. Each step, when we execute in precision with consistency, contributes to better outcomes and fewer complications. Thank you so much. And at this point, I'm going to return it back to Dr. Yu.
Thanks, Lena. So key takeaways from today, what we presented: HOB events are associated with significant higher mortality, length of stay, readmission within 30 days, and cost of care. Common secondary sources of HOB include urine, respiratory, skin and soft tissue infections, and other HAIs like CAUTI, SSI, and of course, CLABSI is in and of itself a subset of HOB. Therefore, the challenge becomes, because there's so many sources, getting a 0 HOB rate is probably not realistic for this particular disease state. So therefore, not if, but when an HOB occurs, identifying the pathogen, getting the patient promptly on definitive antimicrobials as soon as possible may help, along with really robust and revisited risk mitigation practices, may help improve the deleterious clinical outcomes that we reported in our various papers. Finally, appropriate use of invasive devices and sterilization practices in CDC HAI prevention bundles will likely be further highlighted by HOB as a disease state, and which leads us to what can be done now to prepare for HOB. So as alluded to, your policies and procedures that govern how you standardize the best practices for preventing the currently reportable HAIs probably will stand you in good stead, because you can look at it as a continuum where further downstream of a CAUTI, there's a certain number of HOBs. Further downstream from an SSI, there are further HOBs, and of course, CLABSI is an HOB subset. In fact, the National Quality Forum HOB Playbook suggests that your programs for currently reportable HAIs can be the foundational elements of, a anti-HOB program, if you will. And so related to that, practices of cost effectiveness and the best acquisition of specimen collection when it comes to urine samples for culture and blood culture for blood culture results may help decrease the clinical churn in healthcare professional workflows as they're trying to sift through the weeds and actually get to that patient with a true infection, particularly when it's a bloodstream infection, because that has high mortality, as we've shown. And then finally, leveraging the CMS ruling on antimicrobial stewardship programs, which kind of got lost in the shuffle of COVID in 2020, where they require stewardship programs as a condition of participation, but also a committee that includes leadership from your infection prevention department, your antimicrobial stewardship team, your microlab leadership, and also a quality executive that can do something with the synthesized data input from all three of those segments. And so in that way, maybe leveraging things that are already required by both the Joint Commission and CMS might stand you in good stead when you're building your anti and foundational program to tackling HOB. And so with those suppositions, I'll turn it over back to Samantha.
All right. Well, I really appreciate all of our panelists and subject matter experts who spoke today on not only some of the data, like Dr. Yu, the research that he's been leading on the various sources of HOB, so we could better understand for infection prevention strategies, but also those from our team who really work day in and day out on risk factor mitigation strategies in their respective areas. So really appreciate you all sharing and appreciate everybody who joined us today. So we do have several questions in the Q&A, and certainly if you have any questions, please type them in the box. We'll try to get through as many as possible before the close of the webinar, but I think we have about 10 minutes or so. And so looking through here, there's one question that I did want to follow up on in the Q&A, and maybe Dr. Yu, I'll turn this over to you because I know you're doing research in this area. But one question was, what leads to false positive urinary tract infections, or kind of those false positives you were speaking on in your research where you saw about a 30% possible contamination rate?
So, I mean, this is more insights from rounding in the hospital and having an outpatient primary care panel for 2 decades. But a lot of times when patients are given instructions to give a urinary sample, they're supposed to be cleansing in certain areas. They're given a kit. That half the time those things are thrown away and people will not catch the midstream. So that's a good example of not following directions and leading to probably resource waste for outpatients and patients who are sort of have the physiologic reserve to collect their own urine. When you're talking about someone that has a urine Foley, there's also things that you can do which are embedded within the CAUTI bundle. One of the key ones is to not let the Foley bag touch the floor because there's environmental pathogens that are in the inpatient side. And then even collecting the urine, we have a program, which I won't go specifically in, but we have sort of multiple healthcare systems worth of data on sort of ways that clinicians, I think not intentionally, but because there's like surge capacity times with high volume of patients, where they're collecting urine from a urine Foley bag that aren't up to guideline standards. And that's an opportunity, obviously, for contamination from either the healthcare worker or the environment again, or the actual entire Foley apparatus. So, and also the perineal care, I think, is a pretty important that Danielle touched upon, which I think gets kind of lost in the shuffle as well. And it's also hard to do because those patients that with poor physiologic reserve, they're mostly lying in bed and oftentimes their stool is pulled there. So, all these factors individually could lead to a UTI or a contamination situation. And so it's just really trying to recognize that there are multiple risk factors and having a game plan for as many of them as possible and sort of an aggregate effect.
Thank you. The next question, Marty, if you wouldn't mind taking this one, how might HOB initiatives impact vascular access device selection? Do you think that we will see a shift in increased use of central lines?
Oh, that's my favorite question. My hope is yes, we go back to putting in the right device for the right patient for the right intended use, right? I mean, we all know that utilization of central lines, specifically PICs, went down drastically once the CLABSI metric started and has been on a pretty steady state at that point, but utilization is definitely down. And I think a lot of it is, you know, I use the term the criminalization of the PIC, right? Like, let's not put in the device that's going to cause us a problem on the back end, specifically CLABSI. But now, like Calvin mentioned in his study, there were 4 HOB events not related to a central line. So we know that HOB is occurring, and this new proposed standard, if adopted, will level the playing field. And my hope is that, yes, put in that central line, put in the PIC line for the patient that needs it, and not put in multiple peripheral IVs that we are just pushing beyond the limits because it wasn't anything that was reportable or punishable at the time. So that, yes, I do hope that we do get back to putting in the right line for the right patient.
That's such a great point. And yeah, going back to the study that that Calvin mentioned, the fact that there was 4 times as many non-CLABSI HOB compared to CLABSI HOB just highlights that there are so many other sources where this can happen, including peripheral IVs, you know,
Yeah.
could be a potential source. So it's such a
And I
great.
think what's important with that is you know that data now in your facility. You can look at your positive blood cultures on day 4 of all your patients and see who did not have a central line and kind of get a good feel for what kind of problem you may have going on in your facility right now.
Yeah, absolutely. Danielle, here's a question for you, and it kind of similar, I guess, in nature. How do you think the link of urine as a source and HOB will impact the use of indwelling urine Foley catheters? Do you think there'll be an impact on device selection when it comes to urological care?
Oh, most definitely. And I think we're already seeing that and trying to learn which is the best device for the best patient and how to appropriately utilize devices. Certainly with externals, we have seen multiple single center sites report their data in peer-reviewed sources to show decreased utilization and a clear view of decreased utilization. I think we also need some more innovation in this space because external catheters, you know, we have a single contraindication, which is urinary retention, and we still need indwelling for that purpose, whether it's intermittent or you know, an indwelling Foley type urinary catheter. So you know, innovation to help address the problem of retention could help as well. But yes, I think we will continue to see decreased trends and to see the science get excited about ways to reduce indwelling catheters.
Thanks, Danielle. And here's a question for surgery. What are the SSI risk factors that you perceive to be the most controllable or preventable? So Lena, that one's for you.
Thanks, Sam. Well, that's a loaded question, to be honest. I mean, I think off the top of my head, there are multiple things that I think can be controllable. I mean, some of them are patient related. I mean, especially with, you know, timing of antimicrobial prophylaxis, glycemic control, making sure that those are patient driven, but just maintenance of normothermia. I also am a firm believer of proper skin antisepsis. Even operating room traffic control is one of those things that really should be a controllable risk factor as well, along with air quality and ventilation. But even if we bring it down to like the staff level, like sterile technique, hand hygiene, even instrument handling, one thing that I don't think that we always think about is if we're putting implants in and proper implant handling as well. But I really think that maybe those 7, 8, maybe 9 are those controllable risk factors that we could definitely handle, especially with an education around that. So that's where I feel we could make the most impact in the field.
Thanks, Lena. And there's a couple questions that are somewhat related. Dr. Yu, I think I'll have you address these first, but one question is, do you have any advice on how infection prevention departments can work with physician staff on good blood culture stewardship? So for example, reducing unnecessary blood cultures occurring very close to comfort care transitions or in general. And kind of the related question, I think, goes to, have you found anything, in research to help increase diagnostic stewardship while not putting patients at risk? So I think those are somewhat related, if you wouldn't mind taking those.
Yeah, I was going to answer both separately, but one common answer is something I alluded to on the last slide, which is now that antimicrobial stewardship is required by CMS as a condition of participation, which means if you expect reimbursement, they're expecting you to have a stewardship program with specific elements and even a committee with specific leaders. Your typical stewardship program these days, and it's been sort of a thing in the U.S. at least for about 10 years, and some places even more than that. They will typically look at resource optimization and particularly blood culture results, because that obviously has the highest mortality versus a UTI or a skin and soft tissue infection or even an SSI. And so with their limited time, they usually focus in on the bloodstream infections because that's sort of the highest risk in terms of patient care and mortality. And I think they have institutional knowledge and history of like ordering patterns of blood cultures, whether it's appropriate or not, and particularly for patients who are DNR, DNI, but the hospitalist maybe rounds once every 2 months and is mostly an outpatient physician. And so, they might not be as up on sort of diagnostic stewardship. I think that's an opportunity to interface with IPC and the stewardship program in the required committee as codified by CMS to discuss these issues so that there can be a holistic discussion and maybe even a policy and procedure. We are aware of healthcare systems that we've interacted with for various reasons that are embedding within an electronic health record. If you're ordering a blood culture and there was one within the last 5 days already, questions on, have you changed antibiotics within the last 48 hours? Is the temperature Tmax greater than 100.4? Like these clinical qualifiers, which might instigate on the physician side, you know what, I probably don't need another set. And so I think diagnostic stewardship in terms of blood culture utilization is evolving to include that optic of, maybe you don't have to stick them as many times as you want to, and maybe it should be based and predicated on science and data, and also some clinical factors that a lot of healthcare systems are embedding within their EHR.
Thanks, Dr. Yu. This one, I mean, it's somewhat related, but Marty, I'm wondering if you could maybe speak to this. One question says, are there any thoughts on obtaining routine labs from peripheral IVs? I believe this practice may be leading to increased PIV failure and infection.
Yeah, that's a good question. The INS standards, they speak to that. They do recommend using clinical judgment in specific cases when you have poor vasculature of patients, pediatrics specifically. I'm, my history is pediatrics. I worked in pediatric ICU and pediatric ER. We would always draw blood off the labs instead of having to stick a child. But they do. Those are the caveats. So they do mention using your clinical judgment. They also, there is a recommendation there as well that there are products on the market that have it's a device that has a smaller tube that it gets inserted into the catheter and you can draw blood that way. But INS actually speaks to that. It's a good question. Are we causing more failure of that peripheral IV? It's more manipulation in that IV. But as of right now, the only standards that I know of that speak to that are on those special circumstances. The gold standard is phlebotomy.
Great, thank you. And I know we have just a couple minutes left. So let's see here. Dr. Yu, maybe given your background, I'll have you answer this one. So what are your thoughts on staff wearing a mask when placing urine in peripheral devices?
I mean, you're asking the wrong person. I was an infection control officer for like 20 years. I think we have to balance mask wearing with your patient demographics and the overall risk. So I'd say and we actually published on this for immune compromised patients like cancer and transplant patients, where we didn't go over this in this talk, but we did publish that paper as well, and it's open access. But for high risk patients, I think immune compromised either from their disease itself or from the treatment like anti-neoplastic chemotherapy, that is a good idea. But you'd have to work it. I mean, there's all sorts of factors, like are your nurses unionized? What is your policy and procedure as far as masks go for the general population of your hospitalized patients? It would have to go through your medical committee, and the policy and procedures sort of codified and vetted through your C-suite. But overall, I do think there are certain patient populations that reside in certain isolated units, dedicated units for those types that are hyper vulnerable, and therefore we should take every step that we can to protect them because their immune system is not working. So that's my piece on that.
Thank you. Marty, I see one when it comes to vascular access. So there's a question, are there any recommendations for scrubbing the hub of peripheral IVs? And also there's a related question, I guess, of kind of the thought or recommendation for active versus passive disinfection practices for the hub.
Yeah, the INS standard 34 covers that pretty well. There's a lot of studies out there. The short answer is that the studies show that passive and active are both effective ways. There are needle-free connectors. The recommendation is to vigorously scrub the top and the sides as well. But the standard is pretty clear that it should be cleaned, prior to the initial access, and if you suspect any contamination. But the studies actually show that they're both effective. I mean, using an alcohol pad to scrub vigorously is effective, and using a passive cap is effective as well. I think it comes down to, there's a cost factor in there. There's a risk factor depending on the patient population. And some of these products, are designed to fix the fact that we're not compliant with standards. Like if you're compliant with standards and doing things the way they should be done, there may not be a need for that specific device. But then on the other hand, it becomes, well, let's just get that device because it increases our chances of maintaining asepsis. So, but yeah, INS standard 34 goes into a lot of detail, and it lists the studies that they're referencing for the passive versus active.
Thanks, Marty. And I know we're just about right at time, so thank you for all of the questions that have come in. Hopefully we've been able to either answer many of them live, but also I know a ton have been answered in the chat, so thank you to the panelists for doing that. Also, our emails are on the slide here, and I know the slides will be provided to you. So if there's any follow-up questions for our medical affairs team, especially in any one of their respective specialties, whether surgery, urological care, vascular access device, or those more broad infectious disease or HOB program in general type questions. We're happy to have scientific exchange with you all with our medical affairs team. And if it's not us, we can direct you into the right place. We work with brilliant minds who are very well versed in this area. And certainly we want to partner with health systems all around the country to see how we can tackle this very significant clinical and economic burden that our patients are facing every day. So thank you to our panelists for all of the great information you provided, and thank you for everybody that attended today. Have a wonderful rest of your day.